Welcome to the Egg Whisperer Show, a podcast exclusively designed to create more reproductive health awareness and discuss your fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
Hi, everyone. Welcome to the Egg Whisperer Show. I'm so excited to have Dr. Nichole Barker on today's show. Hi, Nicole.
Hi.
Thank you for being on today. So for our audience, I want you guys to know that the title of today's show is How to Avoid the IVF Catastrophe of OHSS. And there's a reason why Dr. Nicole, what do patients call you in clinic?
Dr. Barker.
Dr. Barker. So there's a reason why Dr. Barker is on today's show, and we'll get to that in a sec. But before, I want to read Dr. Barker's bio for you guys. So let's talk a little bit about her. She is a member of the SRM team since August of 2012. She has special interest in assisted reproductive techniques, PCOS, recurrent pregnancy loss, and fibroids, and she received extensive postgraduate training in minimally invasive surgery to enhance reproductive outcomes. She graduated with lots of honors from John Carroll University in Cleveland, Ohio, with a degree in chemistry, followed by med school at Ohio University, and she completed her OBGYN residency and reproductive endocrinology and infertility fellowship training at University Hospital's Case Medical Center in Cleveland, Ohio, where she also served as executive chief resident and clinical instructor for Case Western Reserve University. Welcome, Nicole.
Thank you so much for having me.
So just tell us a little bit about yourself. Why medicine? And more specifically, why fertility medicine?
I think I'm just a natural born caretaker. As I was young, I was always very interested in trying to see somebody was needing help or hurt. And obviously the sight of blood never scared me at all. So I think that and my love for science was a great blend. And reproductive medicine really wasn't my plan. I had definitely fell in love with OBGYN probably pretty early in my medical school. So I knew that was going to be what I was going to do. But when I was in my residency, it was more of just, I think I want to do this. Maybe I'll dabble in this. Maybe I'll just be a generalist because I like everything. And I did my reproductive rotation. And after delivering hundreds of babies and thinking that was what kind of lit my fire, I really decided that actually helping some couple or a person who has been really trying their hardest and struggling to build a family and seeing how rewarding it was to go through that journey with them and them being successful was just so rewarding to me. So I think that I just fell in love with all of that, as well as just the science of reproductive medicine.
Yeah, well, I can definitely hear your passion in the answer you just gave. So I imagine that your patients love seeing you. So tell us about you have a personal experience that I would love for our audience to hear. Tell us about your experience with OHSS, and certainly I'll get to the show topic in more detail.
Sure. So I'm not shy about sharing my story. It actually, I found, has been one of the best things of my career, not so much personally, right? Nobody wants to be infertile and go through treatments. But for my career, I always say that being the patient has really allowed me to connect with my patients. I had been a fellow when we did our first IVF cycle, and it went pretty well. I stimulated well. I had a pretty high estrogen level, got a decent amount of eggs, but I never developed hyperstimulation. I even was pregnant at that time. So when I did it again, it was kind of a surprise, which you kind of think, oh, probably the first time it would happen and you'd be more likely to get it again. I was a little older this time and my estrogens weren't as high. I took forever to stimulate. And then I ended up not feeling so hot a couple days after the retrieval. And I'd planned on a fresh transfer. So I was thinking to myself, am I getting sick? No way. I'm a doctor. I can't. So I noticed that I was having some epigastric pain. I noticed that I was having a lot more pain than I did the first time, and I required more pain medication. Come the day before my planned transfer, I was actually in my office. I think I scanned myself and just saw like a bunch of fluid everywhere. And I called my own doctor, who's my partner, and said, can you look at these images? I don't think I should be doing a transfer tomorrow. And we decided that at that point, we had to freeze embryos. And so luckily, I did not need to be hospitalized or need extra care other than just supportive measures. I was actually able to work. I was working, but it definitely took about a week to resolve, and it is not fun. So, and I'd probably say I had a moderate case, so I cannot imagine how it would feel for somebody with severe.
So what is OHSS?
Yeah, so it's very unique. And I tell my patients that ovarian hyperstimulation is typically in the world of fertility something we want to do, right? We want to stimulate ovaries in most cases and get multiple follicles. And so ovarian hyperstimulation is not always bad. But when it becomes pathologic and you develop a syndrome, the hallmark is that the ovaries are big and you have lots of follicles, but you're also having some other things go on. For instance, some hyperpermeability of the vasculature. So for instance, when you have high estrogen levels because of the follicles, in some people, some serum can leak out and just accumulate into the abdomen. And sometimes it can even back up into the lung and affect the kidneys. And because of that, the blood can become thick. So there's a higher risk of blood clots and obviously in serious cases, stroke. It's one of the things in reproductive medicine that we worry about the most because in very serious cases, it can be life-threatening. And most of the times people get with IVF a very minimal hyperstimulation. Everybody feels bloated. Everybody's ovaries are humongous. And so I always say expect something a little bit like that. But the reality is that something like hyperstimulation is in the severe cases is actually a low chance.
Mm-hmm. And what causes it? I mean, you talked a little bit about estrogen levels, but do we know actually what the cause is?
We think in some people, maybe they have a genetic predisposition, but there's not like a gene that we can test in our patients. And there are definitely people who are at more higher risk, we know. But we believe that when you get down to the science of it all, that there is something called vascular endothelial growth factor, VEGF, which we think is probably responsible for this hyperpermeability and maybe fluid overload that happens in these patients.
And is it something that is only specific to IVF, or can you get it from any other treatment?
Great question. And I tell my patients, even I've seen it with Clomid, which everybody thinks is so benign, but I do think that it's more common to be seen in patients who receive the gonadotropins, which are follicle stimulating hormone and luteinizing hormone. And these can even be done with timed intercourse or IUI, but more commonly with IVF at higher doses. So we do see it more commonly in patients. But yes, even with Clomid, you can get hyperstimulation.
And so I have patients who they've obviously read a lot. They're well read. They've done a lot of research. They've talked to their friends. And they're really scared about OHSS. And I tell them, like, you don't have to worry about that. So is there a patient population that can just not worry about OHSS?
We believe that there are definitely people who are very low risk. Those with maybe low egg reserve or who are not stimulating very robustly. But the reality is that I've even seen it in a very mild case of patients who take Clomid or gonadotropins, even with those scenarios. So for me, I feel like everybody could get it. Does everybody get it? No. But I think that it's important that every patient who takes fertility medications is aware of that and is just looking at the symptoms.
I would say that if a patient is, let's say, over 40 and has 10 follicles or less, the likelihood of severe OHSS is close to 0. So this is mostly for younger women or even older women who have a very high egg count, high AMH. And certainly even with gonadotropins and not doing IVF, say, you can have it. So what are the symptoms? You talked about your symptoms waddling around, but what are the symptoms from head to toe the patient, or however you want to describe it to us, that patients should be aware of?
Yeah, and I've seen it present many different ways. I think the most common is that people feel bloated. They have difficulties really taking a deep breath. I've seen severe nausea be associated with it, constipation, difficulty urinating or stopping urinating. In some cases, swelling of the body as well, difficulty breathing or chest pain. If there's sometimes fluid that's backing up into the lungs, that could also be a problem. Now, if somebody were to have a stroke or a blood clot, there could be other things associated like leg pain or headache or visual changes. But I would say the most common are pain, discomfort, nausea.
And then are there any other conditions that could mimic OHSS that you've seen?
It was not my patient, but I've actually was consulted on a patient who was a spontaneous pregnancy, who had something called theca lutein cysts, and she didn't have even a twin pregnancy. And we don't believe it was associated with a gestational trophoblastic disease, which can also cause that. So high levels of HCG in pregnancy, which twin and GTD can also have. But other things that I could imagine is seeing some of my patients show up to the ER and they didn't tell them or didn't know that they were on medication and were worried that they had abnormal ovarian cyst or even cancer. But as we know, if you're taking these medications, that's not what it is.
Right. And I've heard that before. A patient goes to the ER, not my patient, with pain after an egg retrieval to find out that she's given a diagnosis of ovarian cancer because that poor ER doctor has never seen it before and they haven't seen the number of cysts on an ovaries. They misdiagnosed the patient. So it's so important to have an emergency number, know who to call if you're a fertility patient. So you're getting answers from the expert. Certainly things like a ruptured cyst or ovarian torsion can look like OHSS, or it could be a combination of the two. You can have a ruptured cyst and torsion and OHSS. So important to talk to the doctor that did your retrieval right away. Take us through your step-by-step approach to treating someone who has moderate to even severe OHSS.
Sure. So if somebody is calling or showing up at the office with symptoms that are suggestive of it, I typically do want to see them. I want to lay eyes on them. It's definitely very hard to manage patients sometimes just over a phone call. So I always tell my patients, can you come in? Does it need to be the ER or does it need to be with me tomorrow? And usually I'll examine them. I'll have them do vital signs. I'll do an ultrasound because you can see how big the ovaries are. You can see if there's fluid accumulating. And at that time, I usually check some laboratory tests as well, typically a complete blood count. Sometimes you can see that the hemoglobin and hematocrit are high in these cases because remember I had said that the blood kind of thickens. And I also look at their electrolytes because those could be off. So sodium, potassium, looking at their kidney function is important. And so those are usually my first line, going in, examining the patient, laying my eyes on them, hearing about their symptoms. And then if I feel based on their laboratory testing and their exam that they can be managed, a lot of these patients can be managed from home and they are just given specific instructions to monitor their symptoms. If we have to address pain control or nausea, we do so, as well as keeping track of how much they're urinating because it's a bad sign if you stop peeing. And so they usually are sent home with those instructions and then we're checking in on them daily until they start to feel better. Now, if they're not, or if there's an extreme amount of fluid that's accumulating, sometimes we'll actually remove it. And that's called a paracentesis when you drain fluid from an area, but specifically it would be the pelvis. Sometimes people even need a drain from the lungs, but we would be sending them off to radiology to do that. And in cases where people can't keep anything down, or if their labs are really abnormal, they have to be hospitalized. And we have to potentially even be monitored for their cardiac status, given albumin, or just making sure that overall their other systems don't shut down because of this.
So you've provided basically a checklist for people. Check your vitals, talk to someone daily, check your urine output, measure your weight daily. All those things are important for patients to know who might be at higher risk. So I imagine you're talking to us about how you would treat it, but the reality is you're probably not seeing that much of it anymore because of all the steps that you take to prevent it. So can you talk to us about what you do to actually prevent this before it even becomes moderate to severe?
The reality is that we really have to isolate who are the patients at high risk. And I do feel like over time, we have been doing a great job of doing that because we've seen the incidence of this going down with certain types of medication protocols or freeze all protocols that can minimize that. I would say that the first thing I'll do is look at their ovarian reserve, understand if they have any of the high risk factors, which would include somebody who's maybe got PCOS or just a really robust egg reserve, who's younger, who's got a low BMI, who's had it before. And so isolating those patients up front and talking to them about ways to, how could we avoid this going forward in treatment? So for instance, should we plan on maybe not giving HCG for a trigger, but Lupron for a trigger, as well as freezing embryos, because both of those things can really diminish that risk.
And a couple of things I'm sure you do too is get the patient in early, choose a lower dose for the gonadotropins. You probably see them more often. And then for the trigger, a couple of things that I found to be really helpful helpful are Femara on the night of the trigger, and even for 2 to 7 days every night afterwards, and then bromocriptine nightly until the period starts. The patients and their physical recovery, especially younger egg donors, quite remarkable how quickly they recover after their egg retrieval. When you have moderate to severe OHSS, one question people will always have is this going to hurt me in the long term? Is it going to hurt my fertility? Is it going to make me run out of eggs? What is it going to do to me? Cause cancer maybe. So what are the long-term effects of OHSS, if there are any?
Yeah, so it's typically a self-limiting condition, which means that even though the first 1 to 2 weeks, if you do develop it, are not fun and you have to be monitored closely, it usually goes away on its own. However, I always tell my patients with IVF specifically, you are only stimulating a cohort of follicles and extracting eggs that were destined to not be even used. You will get more follicles and more eggs the next time. So it's not going to expedite somebody's menopause. It's not going to take away eggs that they wouldn't have used. Okay. And even though it's possible that if there's a robust amount of eggs, there might be some signs of poor quality. But if an embryo grows and looks to be a good quality or is even genetically tested and found to be chromosomally normal, I would not say that that embryo from somebody who developed hyperstimulation would have any decreased chances of getting pregnant than another person. And in terms of risks of cardiovascular disease or risks of cancer with this, I don't believe there's any long-term just because this is such a limited disease.
So you can get pregnant with OHSS, right?
You can, and it's actually more risky. And so that's one of the ways of kind of addressing it is if somebody is, let's say, developing symptoms before their transfer of OHSS, we would talk about maybe freezing the embryos because typically those patients who are the sickest are the ones who are pregnant because as you can imagine, the hormones are even more high at that point. And so at least from what I've seen is that my patients have been the sickest who are pregnant with hyperstimulation. And I always say, yes, we want you to be pregnant, but we want you to be healthy and not in the hospital for the first couple of weeks of your celebrating pregnancy.
Right. And so sometimes when patients show up for their fresh embryo transfer, you put that ultrasound on their tummy and you're like, oh no, we're not doing this today. You got to go home and rest.
Floating and you can't really see because the ovaries are in the way. That's a bad sign.
Right. So what would you want every patient to know about OHSS before they start fertility treatment?
Yeah, I think it's important to empower our own patients to understand their bodies and what their risks are. So asking questions to your provider is just first and foremost the most important. So what is my egg reserve? Do you think that I will stimulate well? And if so, do you think I'm at risk for hyperstimulation? If a patient has a history of PCOS, absolutely. They want to be really questioning their protocol and the plan. And trying to avoid it is going to be the number one thing. So asking questions, having patients empower themselves to do that and feel comfortable asking their provider is important. And I do think that nowadays there's definitely ways of decreasing, almost eliminating. I can't say zero because we can never say zero, right? But I would say really almost putting it away, like us not having to worry about it. But I think that it's important to know that there are things that, at least in regards to trigger shot and freezing embryos or a fresh transfer, of ways that we can navigate this and hopefully minimize.
Yeah, that's great advice. So am I at risk for it? What are you going to do to prevent it? So if you're listening or watching, write that down. And there's no question that's dumb. There isn't. The only question that's dumb is the one that you didn't ask. So never be afraid to ask more questions. So do you see any future novel treatments for OHSS out there coming down the road?
Yeah, I've thought about that. I mean, I've done a little bit of digging in the literature and I'm sure you had mentioned some things. I've never done the letrozole, so that's very interesting. I've done cabergoline, which is kind of like the bromocriptine for some treatments. But to my knowledge, I don't know anything kind of new and emerging. And I think that the focus in our field, and correct me if I'm wrong, because you might know, but I think the focus is really just trying to identify those patients at risk and maybe preventing it from the beginning, as opposed to how do we play catch up and treat it? How do we put the Band-Aids on it? How do we prevent it in the first place? And so I'm not sure. I haven't seen anything. Have you?
Not really. I mean, I think we're just all coming up with different recipes. And a couple other things that I do is, for example, ganirelix. I'll just continue the ganirelix, even like the night of the retrieval, the next day. And I've always wondered if maybe like the medication that's similar to Depo-Lupron or Alyssa, if maybe something like that could just shut down estrogen production very quickly for these patients so that they're not at risk. I'm especially thinking for egg donors, because a lot of them fly in for their egg retrieval and then they leave a day later, and then they just don't have as much supportive care in some places in the world, I'll just say, not necessarily in this country, but some of the tragic stories that you hear are not in this country. A lot of them are overseas. So I feel like there could be some ways to help those patients so that they don't suffer after they're giving that gift to another family.
Absolutely. And I do think that using a Lupron trigger, and as not everybody will respond to that. And so in some cases, we must use HCG to trigger. And I've even seen a case of hyperstimulation with a very minimal dose of HCG. I always say a whiff of HCG for a trigger can put somebody into hyperstimulation. And so I do think that it's important for us to know about all these ancillary maybe options. And I think the points that you bring up are great.
Yeah. And I've had one patient in the last 12 years develop moderate to severe OHSS from a Lupron trigger. I never thought I would see it, but I have seen it once. So never say never. We never take our patients' health for granted.
Right.
So, well, thank you, Nicole, for being on today's show. So let us know exactly. Tell our audience, where can they find you? Tell us about your clinic, the name of the clinic, your Instagram handle, all that good stuff.
So I'm at Seattle Reproductive Medicine. I work outside of the Tacoma clinic. We have six different satellites. So that's where I'm at. And I do have an Instagram page. It's fertility specialist _Dr.Barker. So you can find me there. And I have a lot of fun with that, connecting with people and colleagues and educating.
Awesome. Well, thank you, Dr. Barker, for your time today. Thank you, everyone, for watching today's show. Please be sure to subscribe to my YouTube channel and catch the next Egg Whisperer show anywhere you can find us. Thank you again. Bye, everyone.
Hi, Amy.
Thank you so much for listening and making the Egg Whisperer show a part of your weekly routine. To find show notes and a full transcript for this episode, visit dramy.org and look under the blog tab. While you're there, you can find a link for the Egg Whisperer newsletter, which keeps you in the know about fertility news. You can also find Dr. Amy and the Egg Whisperer show on YouTube, Instagram, or Facebook. If you'd like to learn even more, Dr. Amy offers classes at the Egg Whisperer School, eggwhispererschool.com, or you can request a consultation on dramy.org. Thank you so much for tuning in and for sharing the Egg Whisperer show with others. Keep sparkling and have a great day.